Nigeria, Ghana, Cameroon, DRC, Congo, and we are continuing to grow in that number. And what we are hoping is that, like yesterday, we had people from almost 14 different countries sign on, and we're hoping that we can provide this type of training, this type of network, this kind of educational platform for everyone to use. And to Healthy Sunrise Foundation that have all the while has supported the Nigerian Implementation Science Alliance in all the work we do. So thank you all. I will hand you over to Dr. Tonia Onyeka. Dr. Tony Onyeka is a consultant anesthesiologist at the University of Nigeria Teaching Hospital, and she is also the program manager for the Center for Translation and Implementation Science at the University of Nigeria that is coordinating this. Dr. Onyeka, please. Thank you.
Thank you, Prof. And good evening, good morning, everyone, wherever you're joining us from. We would like to welcome you to day 2 of the 2023 NISA Research Week. And today we'll have 2 speakers. I'd like to introduce them. I'll start with our first speaker. So our first speaker is Marcia Ori. She is a Regents Distinguished Professor at the Texas A&M School of Public Health in the US. She has a long-standing interest in aging and public health, and her research focus is usually on factors associated with healthy aging and social, behavioral, environmental, and technological solutions for promoting health and well-being. She is the founding member of the National Working Group of the REAIM Planning and Evaluation Framework. I'd like to welcome you, Marcia. And the second speaker is Dr. Babayemi Olakunde, who is an epidemiologist and health services policy researcher. His interest is in HIV and HIV-related cancers, and presently he is the Assistant Director at the National Agency for Control of AIDS. He's also a Senior Research Fellow at the Center for Translation and Implementation Research at the University of Nigeria. So I'd like to welcome the 2 of you to today's session, and I would like to start with Professor Marcia. Welcome, and we'll put up your presentation so that you can begin. Thank you.
Thank you so much. I think you probably want to put it on slide view. Excellent. I am so pleased to be with you virtually today, and to sort of, I hope in the future to be part of your practice-based research network. You know, so I feel, as you say, passionate about healthy aging, and I think healthy aging should be the new normal. But my new passion is all around translational research. So I am just thrilled to have this opportunity to share and learn from you. Let's go to the next slide, please. So what I want to do is sort of start with an origin story. And it's going to be my story as well as REAIM's story. And that's the D&I model I'm going to be talking about. So I'll talk about some REAIM elements. I want to give some case uses. These are going to be in the healthy aging field. I think it's important, since REAIM has been around for about 20 years, to talk about some common misconceptions, what we see REAIM being, and talk about its evolution and related frameworks, and then end up with some resources. So we can go to the next slide. I think we all have our own professional and personal journeys. Mine started more than 5 decades ago. So I have graduate training in social sciences. I too am a sociologist and public health. I take a life course perspective. That is, aging starts from birth to death. I spent 20 years at the National Institute on Aging, and there we were all about research discoveries. What I liked best about my time at NIA were the collaborative efforts, and I think that's what's so wonderful about your research network. I've been at A&M for about 20 years, And my area, again, is the nexus of aging and public health. But instead of the research discoveries, I'm really focused now more on research translation. I'm affiliated with the Center of Community Health and Aging. And I think why I'm here today is I'm a founding member of this national working group on re-aim planning and evaluation. And I'll be talking more about this, but this is our website if you'd like more information. So going to the next slide, let me just talk a moment okay, so this is the origin story of re-aim. And so Russ Glasgow is really the person who I would say is the birth father of re-aim. So more than 20 years ago, he and other colleagues were really lamenting about the lack of comprehensive evaluation frameworks for multi-level interventions. And they thought, let's have a new way of looking at public health impacts. And here it was looking at the reach, the effectiveness, adoption, implementation, and maintenance. And I'll go over what these 5 domains are, because I think it's important to understand each domain and then the interaction across the different components. I think what this framework does is it emphasizes the importance of looking at interventions and assessments, but matching them to your setting, to your goals, to your purpose of research or practice. And then I think what's important is to look at counter forces across these different elements. What was also important about re-aim is this concept that you needed both efficacy research, and that is internal validity research, as well as translational research that would help you understand external validity. So what we do see is that these efficacious interventions may not be translatable in the real world. This was the origin of re-aim. So if we go to the next slide, what you'll see are the different components. And I think you can look at the solid line, and you can say that you'll have some interventions that have high efficacy, but they may have low reach. And that means they may be adopted not as well, they may not be implemented as well, and they may not be sustained. On the other hand, theoretically, you could have intervention that might have lower efficacy, but it would reach more people. It would be more likely to be adopted, implemented, and sustained. So again, think of the components and how they interact with one another. So going to this next slide, almost every translational researcher talks about how long it is to get from research to practice. And this classic study that talked about 17 years, they've updated the study and it's still 17 years or more. But we see it's not only how long it takes to get from research to practice, but how much of the research actually reaches the person, the target that they're intending to reach. And then how many people, administrators and practitioners, report that they actually use an evidence-based practice frequently, and this is less than 1 in 5. So if we go to the next slide, I think that one of these problems with this research to practice gap, even if you have an intervention that's 100% effective, it's only going to be as good as it's adopted, as you have practitioners who are delivered to train it, as it's delivered with fidelity, as populations have access to it, and it can be sustained. So you can start off with 100% effective intervention, and you'll end up losing all along the way, so you'll get a very small benefit. And I think this is what the sort of issue about traditional research traditional RCTs versus the real world setting. There's going to be a voltage drop in effectiveness because of all of these domains. And what's really important is to keep asking what is most important to the stakeholder. It could be 100% effective, but if it's not important to the stakeholder, you won't have adoption. Let's go to the next slide. Are we on the next slide? I'm going to turn off. Yeah, I'm going to turn off my. Okay, so the next slide. Yes, perfect. Now we're on the next slide. So this is really a sort of illustration of the gap between research on the right and practice on the left. And this is where I think dissemination and implementation science comes in. Again, D&I science, I think all of us know, is that systematic study of how evidence-based interventions, practices, and policies can be integrated into healthcare and community settings. So we see that dissemination is information sharing. We see implementation is the integration of the intervention, the practice, or the policy. And we feel in REAIM really strongly about pragmatic research. And this is, what is your research under usual conditions, research that's both relevant to stakeholders and it's rigorous. So our next slide, please. Are y'all on the next slide? Tanya, are we on the next slide?
Yes.
So let's do a
I'm
switch.
sorry, the network.
Let's do a switch. Let me take over the driving Marcia. Give me 1 second, and then so I can take over the slide. Hold on 1 second for me.
So I just went on the dissemination and implementation slide with the definitions.
Okay, I am going to get there. Okay, let me start sharing so that I can take over this. Hold on 1 second. All right. Hold on 1 second.
Okay. And for some reason, my computer is frozen. So I am so glad that I shared my slides with you.
Yeah, that's very helpful. Okay, now let me get the, hold on 1 second, what's happening? Okay.
I think it's slide 10. Let's go to slide 10. Were people able to see all the slides before 10?
Yes.
Okay,
yes,
perfect. Okay, so now we're on slide 10.
This is where we are.
I talked about this slide. Did people hear this slide or did I freeze?
So can you see this slide?
Yes, that's perfect. When we talk about okay, thank you. When we talk about D&I science, everyone knows there are so many theories. There's probably 150 different theories, frameworks, or models. And there are different definitions. So theories are that systematic way of understanding interrelated concepts, definitions, propositions. Then you have frameworks, which are the strategic action planning models, and they provide a systematic way to develop, manage, and evaluate interventions. And then thirdly, we have models, which can be used to describe theories and frameworks collectively. So let's go to the next slide, please.
Okay, something then is wrong with the slides.
Okay.
Okay.
So the slide, I'm not seeing how, okay, perfect. Okay, we're going to get in sync. Where do you find DNI models? There are DNI models that are a lot of places, but this is one of my favorite websites. It's the www Dissemination-Implementation Organization. And they've actually redone this quite recently. And so it's continually being updated. But what's important is that you can see how to select a slide, how to adapt it. They've now added combining different DNI models. They've looking at the integration, and they're also looking at the measurement. And just recently, they've added a lot about health equity. So if you flip back on, you'll see that this toolkit has a whole new look and many different things that you might look at. So let's go to the next slide. In choosing a DNI model, everyone loves this sort of quote. Nobody knows where it's come from, but it's like theories are like toothbrushes. Everyone has one and no one wants to use anyone else's. And so when you're thinking about the realm of 150 different theories or models or frames, it's really important to think about the key constructs that are relevant to your project, whether you're talking about adoption or adaptation or translation. What level of the social ecological framework are you looking at? The individual, the family, the community. What is your purpose? Is it for dissemination? Is it for implementation? Or is it for both? And then what's the content area or the context of your project? And then I think when you're choosing a DNI framework, it's important to look at pragmatic issues. That is, how long has a framework been used and how easy is it to use? And this is sort of why we've chosen REAIM. Can we go to the next slide? So we think that REAIM optimizes external validity and pragmatic criteria. And these are often ignored. By optimizing these crucial elements, REAIM serves several purposes. First, it helps to facilitate the translation of research to practice, and we've already talked about the gap. Secondly, it balances internal and external validity. Thirdly, it emphasizes representation. And that's not just in terms of reach, but it's along all of those different components. And then I think what's nice is that REAIM can address multi-level factors, whether we're talking about individual, organization, or system level factors, and research, whether it could be experimental or observation. Can we go to the next slide, please? This slide gives us a sort of overview of the goals of REAIM, both its intervention goals and its implementation goals. So our goal is that we want to have programs that can be adopted, they can be adapted, they can be delivered broadly. We also want programs that have the ability to be sustained at a reasonable cost. We also want programs or practices that reach large numbers of people and that are replicable and long-lasting. So that's why you'll see the 5 different components. Let's go to the next slide and we can look at each component separately. You can see the technical definition on the left, but I want to focus on the pragmatic definition. because I think that's what's practitioners are going to focus on. So for REACH, the question is, who's intended to benefit and who actually participates or is exposed to the intervention. So that's what REACH is. Let's go to the next one, please. The next one is effectiveness. And so the pragmatic use is understanding what is the most important benefit you're trying to achieve and what is the likelihood of negative outcomes. So again, looking at both positive and negative. The next one is adoption. The pragmatic use here is where is the program applied and who's applied it. If we go to the next slide, you'll see implementation. And I want to spend a moment about this one because this is one that REAIM has thought a lot about. So the pragmatic use is how consistently was the program delivered? How was it adapted? How much did it cost? And again, why did the results come about? We want to sort of understand the how and the why. But what's really important about implementation, I think over time, there has been, before, I think the emphasis was on fidelity. Now the emphasis is on adaptation and cost. And these are things that have only recently been adopted, I think, in D&I literature. But still, some people don't look at both the positive and the negative outcomes and the cost. When we go to the last component, this is maintenance. And the pragmatic use is understanding when was the program operational and how long are the results sustained. So it's both programmatic as well as client-based for who gets the results and how long they can be maintained. Can we go to the next slide, please? So I've had experience with REAIM in national initiatives. These are major organizations. In aging, the Aging Services Organization is the Administration for Community Living. The public health major organization is Centers for Disease Control. NIH represents our premier research institutes, and the Robert Wood Johnson Foundation represents a major private foundation. And what's interesting is all of these major organizations have mandated in some way the use of REAIM. So what I want to do is sort of talk about my own vision, my vision of having evidence-based programs that are widely available and easily attainable to older adults. And so drawing on my own experience in the Aging Services Network, the last director in my county, what he had this vision is he wanted to have evidence-based programs just like Starbucks. He wanted them everywhere in the community and in places designed to make people feel comfortable. And if you look at just one of these programs that I'm going to be talking about that have rolled out widely in the US, it's chronic disease self-management programs. Whether they're generic chronic disease or diabetes self-management or chronic pain and management, or even chronic conditions in the workplace, there are common themes and frameworks across these public health issues. And in this case, chronic disease self-management, but whether you talk about programs, policies, or practices. Can we go to the next slide?
I'm sorry, I am trying to move this.
Well, you're moving better than I would be moving, so thank you.
Okay.
It'll go in a second.
Okay. Okay, let's do one more time. I never had. Okay. Okay.
Okay, perfect.
It does.
Okay, so this is an example of an incredible success in the aging network. That is delivering over, when we first, back in the early, 2000, we were so excited when 100,000 people in the US had engaged in these evidence-based practices around chronic disease self-management. And here are some references. Now, at last report, over 500,000 people have engaged in these programs. So you can take programs to scale. But let's go to the next slide. If we can go there, and we can talk about how you have a program go to scale and become successful. I think there are 3 M's to success. And again, I'm going to be using the example in the Aging Care Network. Let's think about the moment. That's recognizing the high prevalence, the cost of chronic conditions, recognizing the power of evidence-based programs, and then recognizing translational research. So we had this moment. The moment turned into a movement. And I've already talked about the Administration for Community Living that sort of took up the banner of evidence-based programs. Then they had a National Council on Aging that served as a technical assistance arm, and they mobilized the whole aging services network. That's how we got the 500,000 people and counting in these evidence-based programs. But we don't want to just stop with the movement. We want to go to momentum. Can we go back to the momentum slide? So what's keeping the momentum up? I think it's an emphasis on person-centered care. It's now having reimbursement for evidence-based programs. And it's why we're here today. It's talking about the momentum that we're going to get from D&I science and practice. Now we can go to the next slide. So when we think about building the evidence-based movement, it's this National Council on Aging, and their motto is, it's never too late for prevention, and they really sponsor a whole variety of evidence-based health programs. So they started with the chronic disease self-management program. Its first paper was in 1999. That's the same year that Russ Glasgow talked about re-aim. But so you'll see that CDSMP is now got huge momentum, but it's taken 20 years. And how did they do that? The Administration for Community Living, they had evidence-based demonstrations across the country. In 2009, we had an American Recovery and Reinvestment Act. What's really interesting is policy. In 2012, if you wanted to get money for funding for aging services, you had to use evidence-based interventions. And then they continue to support demonstration of the dissemination through the Aging Services Network. So it really takes a whole village, I think, to bring programs to scale. Let's look at the next slide, please. So, we talked a lot about how do you choose a D&I model. I think it's the same thing about how do you choose an evidence-based program. In the aging services, as in many other fields, please don't start from scratch. There have been many different programs tested. There's a growing inventory of evidence-based programs. And what's interesting is that these evidence-based programs are now being rated on implementation and dissemination factors. And there's training and technical assistance available. So this is just one example of how you can go to scale. Can we go to the next slide, please? What I'd like to talk about is some of my own research on early D&I efforts in the aging services sector. So the National Council on Aging, who were the technical assistance arm, highly encouraged that the grantees use the re-aim model. And so we came back through the grantee program and we had this question: could the aging services sector successfully employ a D&I model in the field? And so people in the aging services sector, they are not researchers, they are not clinicians. They're the people who are providing services to older adults, and in this case, health promotion and disease prevention services. So we did a survey, and here's the reference you can see. And what you'll see is that the stakeholders reported high perceived utility, whether they were talking about reach or effectiveness, implementation, adoption, or maintenance. But what they said, and these were practitioners, it was difficult to track all the elements in the field. They recognized the importance of them, but they also said, unless there are sort of resources, they said our business is delivering services, not necessarily tracking. However, I think what's also changed since this research, if you get money from a foundation or the government, there's now a bigger expectation that you will track what's happening to your program so you know if it works and for whom. Can we go to the next slide? So the next slide is a recent example. Diabetes is a major problem in South Texas, which is heavily Hispanic. And so the question that we wanted to ask is, can we deliver a culturally relevant, practice-based diabetes self-management education program that will improve the health of underserved populations who often lack access to medical care? And, you know, just like with the Aging Services Network, the question was, who can make this happen? Who's going to have the momentum? And this was part of a Healthy South Texas initiative that was heavily funded through our state. So let's go to the next slide. So this was a target of adults living with diabetes, 215 to 219. The program we had was an American Diabetes Association program. It was a 12-month program. It had about 8 hours of in-person workshop education and then follow up with individual problem-solving, goal setting. And it was delivered by community health workers and health educators. So how did this program score? For reach, really high, it reached about 8,000 people. For effectiveness, really high, it reduced A1C levels, it improved diabetes self-care behaviors. It was widely adopted by healthcare settings, by community settings. But the implementation was not good. And the reason why is that it was basically still research driven. People would, be invited to participate. You'd get 20 people who would say, oh yes, I'll be at a workshop. You would call them the day before the workshop and they would say, oh yes, we'll be there. And then the day that the workshop happened, 3 people would show. And so that's why I think it's really important to not only have a highly effective program, but have one that can be implemented. For those people who did go to the program, there was high maintenance in terms of still having those reduced A1C levels and improved self-care maintenance. But implementation, as I said, is often difficult. You sometimes only get people in the program who want to come and think of the missed opportunities for everyone else. Let's go to the next slide, please. So we revisioned this diabetes education program at the border, and we called it Making Moves with Diabetes. The first thing we did is we made it more standardized and manualized. We gave it a shorter intervention time frame, thinking it was way too long before. It got rolled out during COVID, so we had both virtual and in-person versions. And we paid so much attention to getting people in the program and then keeping them in the program. And our outcomes were even stronger than in the program I just talked about at the border. So the message that I see is it's really critical to understand what works and what doesn't, and to adapt the implementation strategies while adhering to the essential intervention strategies. So you can adapt, but you still have to have your program be evidence-based. Can we go to the next slide? So what are we doing now? Our newest idea is to go from compensatory actions, that is trying to reach out a little bit broader, to the next generation of interventions. And there's a terrific article on this that's come out. I don't have the reference here, but I can get it to y'all. So the new program is called Live in Control. It's an adaptation of two previous evidence-based diabetes self-management programs with both Hispanics and with African Americans. The key adaptations are an even shorter intervention period, but culturally sensitive for minority populations. It was actually co-developed with the populations. And instead of just being individually oriented, it draws family support. So the family is learning with you, and it's also lay-led. But in addition to this innovative intervention, it's set within a 3C community context. So you have to understand the community character, the community context, and community capacity. So we're having people in the workshops actually link people to community resources proactively. So if the problem is, yes, you tell me I need medication, but I can't support it, they'll link you to somebody that can help with your medications. Or if you say healthy food is important, they'll hook you up with a food bank. Or if you say, I just can't be physically active, my neighborhood isn't safe, they'll give you some suggestions about being safe and being physically active. So these were my case examples. Let's go now to another issue, which is the misconceptions. And I'll read them and then go into some detail. The first misconception is that REAIM is only for evaluation. The second is that it's only quantitative. Third, that it mandates that all dimensions are equally important. And fourth, that there are rigid time points for maintenance. So let's sort of go through some examples of these misconceptions. The first one is that we can map strategies. And so here's an example on the left of a program that was for childhood obesity, sort of healthy eating. And it was looking at effectiveness and maintenance. But you can also have examples where you can have dissemination strategies. So you can try to understand, how can we improve reach? How can we improve adoption? Or you can have REAIM help guide implementation strategies. That is, what do we know about adaptation, unintended consequences? And again, how can we maintain our program or practices for the long haul? Let's go to the next slide, please. The next slide is sort of getting under the hood. And here's an article, Qualitative Methods Can Help Researchers Look Under the Hood. And so we really value mixed methods research because that gives you so much more depth and richness about the implementation processes and the results and how those results came about. So this is an article that I would recommend that people look at. The next slide, please. This is advanced consideration of dimensions. And remember when I talked about that early study of how communities of practice had trouble looking at all 5 dimensions at one time? You don't necessarily have to look at all 5, but what's important is you specify in advance what impacts and outcomes are most important to you. And then you provide a rationale for why you're looking at some dimensions and why others aren't addressed. So you don't have to do all 5, but be very logical and proactive about the dimensions you do choose. Our next slide, please. So maintenance, the very first article, remember I talked about the origin story. The very, very first article had an idea that maintenance would be 6 months at the individual level and 2 years at the setting level. But now we realize you shouldn't have fixed terms. You should really have the maintenance be in terms of the problem you're trying to look at, the research question, what the intervention is. And you can actually operationalize maintenance in many different ways. And with Russ Glasgow and others, we actually had a health maintenance consortium where for some people, maintenance could have been 18 years. For other people, it was more like 6 months. So you can operationalize it according to what you expect, how long your intervention would last. And in some cases, you might need boosters and what your research question is. So let's go to the next slide, please. How has REAIM evolved over 20 plus years? First of all, incredible productivity. There have been more than 700 articles, lots of citations, and new content areas. And so the emphasis now is on areas that we didn't emphasize as much. So attention to what it costs to implement, what resources it costs, what the adaptations are. You can't expect a program developed 20 years ago to be the same program for every population in every setting. There will be adaptations. And as I said, what's pushing the momentum is, again, this emphasis on patient-centered outcomes, outcomes that matter to stakeholders and the people who are getting the services. Next slide, please. So this slide really shows, I think, both the complexity and the creativity of REAIM. So it's important to start collecting data on the representativeness, not only of reach, but of all of the components. So we want to know why people participate, why they don't participate at both the individual and the setting levels. But we also want to encourage people to use mixed methods. I talked about getting under the hood so we can better understand implementation issues, and we can look at those multiple dimensions and understand how they work together to get overall impact. Looking at the relationships across those different domains. And I think what's really important for REAIM is to be transparent. Be transparent on your 5 dimensions, whether it's REAIM or everything else, especially about what you had to adapt and if there were any unintended consequences and how you dealt with them. So let's go to the next slide. There's been a huge evolution in REAIM. We're now talking about what we would call a PRISM REAIM model. So if you're familiar with PRISM, that's the pragmatic, robust implementation and sustainability model. It looks at conceptual factors. You can see both external context and internal context. Many of the D&I models look at this. And then we look at, we paired PRISM with REAIM so we can see how the context is going to impact intervention components, implementation strategies, the inner outer context, all of the REAIM dimensions. And then we have these overarching issues. What I think is really important is in the future, we're not considering PRISM and REAIM as separate models, but we're really seeing them as one integrated model. And so if Russ Glasgow were here, this is what he would say, repeat after us. PRISM includes REAIM. You need both of them together to understand public health impacts. And can we go to the next slide? In public health, everyone is sort of trying to focus in on health equity, reducing health disparities. This has become a huge issue. And what we see about the REAIM elements is that each element addresses a key disparities issue. So that is in REACH, are you really assessing those vulnerable populations through how you're targeting outreach methods? Are you understanding the characteristics of people who participate or who don't? And when you look at effectiveness, is you're getting the same effect across different populations? And when you have adoption, are you getting the programs in low resource settings with a variety of staff? What about implementation? Are you monitoring the implementation to understand consistent delivery across different subgroups, and the transparency of documenting those adaptations? And then maintenance is every group, and particularly vulnerable groups, are you understanding how inequities might impact maintenance and planning and supporting sustainability? Let's go to the next slide, please. This next slide is again something new in D&I research. There have always been logic models in public health, but here Smith has given you a sense of logic models for implementation research. So looking at determinants, those factors that prevent or enable the intervention, the actual implementation strategies that will get your intervention in place. What are the mechanisms of operation? And then what are the outcomes? So it's really important to think about this model and how your D&I model that you use does this. But Smith is the person who sort of developed this. And there's a website that we talked about, that dissemination implementation website. It contains fillable logic models. So I think the ante has gone up. If you want to get funded for D&I research in the US, most people are doing logic models, and you can look and learn about it if you're not already familiar, and you can use fillable forms. Can we go to the next slide, please? This slide illustrates what we're calling the REAIM outcomes cascade, and sort of think about how you might approach new programs, policies, or products. They're usually rolled out, even though R comes first, they're usually rolled out by adoption. And so that's taking the community into account, tailoring to engaging leaders, stakeholders to understand the types of settings that will participate. And then it's the implementation. And we want it to be pragmatic. We want to make the implementation simple, low cost, less burden, and provide support. And then when we talk about reach, what we want to do is think of multiple channels to increase access. We want to talk about effectiveness, and that is to utilize the evidence-based resources and strategies that make data evidence-based, and then to provide ongoing support. So you can see this cascade that talks about the re-aim steps, then the gaps where you might lose impact, and then potential ways to minimize that drop-off. This is another slide that sort of reiterates what we talked about at the beginning with the voltage drop. And let's go to the next slide, please. So what are our lessons learned? One, re-aim is one of the most widely used frameworks. I talked about its citations and how many papers have been written. It's often mandated by funders. It's been expanded from the original model to focus more on adaptations, sustainability. The qualitative methods are important to understand the how and the why. It's so critical to capture costs. We want to understand health equity issues at every domain. Please think about pragmatic use, and then think about packaging re-aim not only for researchers, but for non-researchers in the field, and then the integration of re-aim with other models. So let's go to the next slide. And now we're calling this PRISM re-aim use tips, because we see ourselves as an integrated model. What are our tips? First, select a D&I framework that matches your study purpose, your setting, your population. Consider combining different frameworks as needed. And you can see we've combined PRISM and re-aim. Apply the chosen framework throughout the research and the proposal. Don't just talk about a model in the first paragraph of what you do, but really think about how it plays out through the whole process. To document the adaptations both before, during, and after implementation. To choose pragmatic assessment measures. I think this next one's really important. That is, plan sustainability upfront with the end in mind. And we wrote an early article on that. But remember at the very beginning, I said context was key. So again, remember that context is everything, but it's also ever changing. The context doesn't stay stable. So let's go to the next few slides. These are some key resources that will be in your slide bank. And the next slide, please. This is re-aim. It's our website, and it has a lot of resources for you. Calculators, checklists, toolkits, a list of webinars. And we really hope that people from this network would join our webinars, just like we hope to join yours in the future. And then the next slide. This is how to get a hold of people in our center. And the next slide. Now I think if we have time for questions, I'm so pleased to reflect on any questions you may have.
Thank you, Prof. And you have two questions. So The first one says, yes, you do. So the first one says, thank you very much for the presentation. How can we use the implementation frameworks like re-aim to enhance process evaluation of trials of complex interventions?
Well, I think that you can have a complex intervention, but you could still use re-aim around those 5 components. Who are you reaching in your complex intervention? What is your implementation process in terms of adaptation, the acceptability, the feasibility? So I think that the re-aim is trying to make things more pragmatic, but it doesn't mean that it's not appropriate for very complex interventions. There are other models that, and you're going to hear 5 different models this week, Some of them start off being very, very complex. I would say the beauty of REAIM is that it focuses on 5 different components, but you peel the onion for each of those components, and that's what gives you the complexity. So REACH has a lot of dimensions behind it. Implementation, we talked about it. So I would say you can use a pragmatic model for complex interventions. I hope that answered the question.
Yeah, thank you. Then the last question before Dr. Olakunde comes on is, how can researchers use REAIM to assess or measure maintenance when the study or the intervention is not long-term?
Okay, so maintenance, and that's what I said, maintenance is, could be 6 months. I don't know how long the person is thinking, but what you have to do is you have to start at the beginning. Remember I said sustainability starts from the beginning. So when you first get to your program, you have to decide, how long do we think the intervention effect will last? What can we do to build it into a clinical setting or into a community setting? So in that way, no matter how long your intervention is expected to last, you still want to know what you should expect. So, and who will support it. Interventions don't maintain on themselves. They have to be embedded in community or clinical settings. So the question is, no matter how long you want it to last, you have to think who's going to adopt your program and who's going to support it after it ends. I hope that helps you.
Thank you so much, Marcia. Thank you. So,
Thank you.
Professor Zanole, over to you, please.
Just a few minutes, if you take a time to look on your screen, one of the things we try to do, as you remember, is the platforms we have for training and education in Nigeria. I just want to make sure that most of you are aware of that, and that's one of the benefits of being a member of the Nigerian Implementation Science Alliance. So one of those benefits is that we do have a weekly research in progress, where you have an opportunity when you have a research project to be able to present it to a team of investigators who all have signed some form of non-compete or non-usage of your intellectual property, and we're able to discuss your research during those meetings. It's a closed meeting for investigators that happen every week on Mondays. The other program that we have is the monthly webinars that we bring to you when we bring in individuals to speak on a particular topic. The other platform is what you have this week, and you see the way we try to do it is to bring experts in this area, as you have just heard from Marcia, and then we're actually going to bring Dr. Olakunde, who is a local-based investigator who have actually used this infrastructure in Nigeria to provide additional context to how you working in Nigeria can use REAIM. The last part of the platform is the NISA conference. So the NISA conference is where you have an opportunity to share the work you are doing. Yes, a lot of people take their work to the US and take it to London to present it, and after they hope that people in Nigeria will adopt it. How will people adopt something they don't know about? So one of the things we have done is that before you travel to present that in US, before you travel to present that in the UK, we give you an opportunity to share your work in Nigeria with other researchers. That is how you start the process of sustainability, adoption, and scale up. So this gives you an opportunity. Abstract ends June 30th. To take a chance to submit your abstract and share your work with those. What we end up doing is, out of the abstracts submitted, we take what we call the NISA top 10. These are the top best 10 abstracts, and usually we have reviewers from NIH, from CDC, from USAID, both external and internal teams evaluate this abstract to select these best 10. And for those best 10 abstracts, we support them to get them to manuscript. So I urge you to visit the website, nisaresearch.org. It's going to be on the chat. And also you can visit our website, citia.org, which is also on the on the chat box so that you can register for this conference and have an opportunity to present your abstract and also network. We're hoping that one day Marcia will be physical in Abuja and you'll get a chance to meet her. So that's one of the things we hope that as we bring you these things that, yes, we will have a chance to be in Abuja and then people can actually, you get to meet investigators in Abuja who use REM. I'm looking up to that day, and at least they can have a dinner with you and tell you about their work. But thank you all so much as we go to the next phase. Thank you.
Thank you, Prof. So we would like to call on Dr. Babayemi Olakunde to give his presentation. Thank you.
Thank you. Can you see my slide?
Yes, we can.
Right. Thank you very much. And thank you so much, Professor Marcia, for that wonderful presentation. You laid a very strong foundation for my presentation. So today I will be talking about how we've used REM in one of our projects in Nigeria. Okay. So this presentation, I will give short background about the project. It's called Access, the implementation science framework that we used in the project, we are using in the project, and which of course include the REM and how we operationalize REM, and as well as some of the challenges that we faced in using REM. Please permit me, my internet is a bit unstable. Let me just, okay.
If you have a problem, you can also send it to me and I'll share it.
I think I found it. Okay. So the study is called Access study, and Dr. Olarapo talked about this yesterday. He touched on some of the things I'll be talking about today. So it's called Access study, accelerating cervical cancer elimination through the integration of screen and treat services. It's an NIH-funded Year 1 implementation science grant with Dr. Gregory Aarons of UC San Diego and H.Ezona Ezanole of CTI UNN as the multiple principal investigators. So it's a hybrid type 3 cluster randomized trial. I think on Friday we'll be having a session on hybrid effectiveness implementation and design. But basically, it's in this study, we are testing implementation strategies while we're also collecting data on clinical effectiveness. So this study is being implemented in what we call the NISA Model Innovative Research Center. So we have about 21 high volume HIV sites that we've designated centers for multi-center research for implementation as well as clinical research. So this study is being implemented in 12 out of these 21 sites. The sites have about 60,000 women living with HIV in care. It's a good infrastructure for research, and you can see more about the sites in the paper by Olarapo and colleague. But currently, this access grant is being implemented in 12 out of those 21 sites. So we have 6 sites that are randomized to what we call the core strategy, and another 6 sites to the core plus strategies across the sites are across the 6 geopolitical zones of Nigeria. So why access? Why this study? Oh, we all know that cervical cancer it's the second most common cancer in women in Africa, and a large contributor to cancer death. While in high-income countries, there's been reduction in mortality from cervical cancer. In low-income countries, the deaths are actually increasing. It is even projected that by 2030, about 106,000 women will die annually from cervical cancer in Africa. Also in Nigeria, it's projected that deaths will increase, from about 8,000 in 2020 to about 15,000 deaths by 2040. Women living with HIV are at increased risk of cervical cancer. They are 6 times more likely to develop cervical cancer, and they're more likely to develop it at younger age. However, cervical cancer is preventable and curable if diagnosed and treated early. And one of the interventions for the prevention is screening and then treatment of precancerous lesion. But despite the availability of low-cost screening methods such as the VIA, the uptake of screening or screening coverage is still low in many sub-Saharan African countries. Recent systematic review estimated about 13% coverage. In Nigeria, it's about 14% coverage among eligible women. Over the years, there has been a lot of investment in the HIV response in many African countries. For example, in Nigeria, PEPFAR has invested about over $7.8 billion in the response, in HIV response, in the last 20 years. And this, infrastructure is something that can be leveraged to deliver cervical cancer screening and treatment services. Well, despite the benefit of integration, it has not been widely implemented at scale or yielded the desired, result. And one of the challenges has been the limited understanding or paucity of evidence on effective implementation strategies to integrate cervical cancer screening and treatment into HIV care programs. And for these strategies to be effective, it's also important that they are tailored to address, the multi-level barriers that affect both the supply and demand for cervical cancer screening and treatment services. So our study aims to identify effective implementation strategies to enhance the integration of cervical cancer screening and treatment interventions into existing HIV programs in Nigeria. We have 3 main aims. The first one is to refine strategies from our implementation mapping to integrate cervical cancer screening and treatment with existing comprehensive HIV treatment program. So Dr. Olawepo talked about the implementation mapping yesterday, how we identify barriers to cervical cancer screening, as well as a map, strategies to address those barriers. So aim 1 in this grant is looking at to refining or tailoring these implementation strategies to make them, more locally appropriate or culturally sensitive. Then aim 2 is to determine the comparative effectiveness of the core versus core plus implementation strategy. So I'll still talk more about this, but I mentioned yesterday that we co-created from the strategies, the core and the core plus implementation strategy. So in aim 2, we'll be testing and comparing the effectiveness of these strategies. And while aim 3 is to assess the sustainment of the integration of cervical cancer screening and treatment intervention into HIV treatment program. So we, for this study, we integrated 2 frameworks. First one is the EPIS framework. I think on Thursday, we'll be looking at EPIS framework. So EPIS for us was the process and the determinant framework for this study. But for our evaluation, we are using RE-AIM framework. But just like Professor Marcia said, of course, RE-AIM is you can use it as well as determinant when you combine it with other framework. It does not necessarily mean it's not necessarily for evaluation alone. But for this study, we are using it as our evaluation framework. So this is just showing our implementation strategies, for this study. Like I said, the first phase in what we did was to identify barriers to cervical cancer screening, and also to map strategies to address strategies that could address those barriers. And from that, we had what we call the core implementation strategies, and the core plus, which are enhanced implementation strategies. So the core plus are just 2 additional strategies to the core implementation strategies. But in our aim 1, which we recently concluded, we refine those mapped strategies. So it was done at two levels. The first level, the refinement was by the investigative team, and the second level was by the healthcare providers in those health facilities that will be implementing the study. So we had like a focus group discussion for them to look at those strategies to see if they are locally appropriate, if they are also things that can be implemented in those facilities. So at the end of the day, we have 7 strategies in total, the 5 core implementation strategies, then additional 2 to that, the core plus enhanced implementation strategy. So this is what we'll be implementing. The refined strategy is what we'll be implementing in our aim 2. Also, this is just a logic model of our study. So like I said, we have the barriers that we looked at and implementation strategies that we'll be implementing to address those barriers. We also have what we call the mediators that we'll be looking at. These are variables that may, account for the relationship between the implementation strategies and the outcome. So like organizational readiness, implementation climate, implementation intention, self-efficacy, and of course we have the outcome. And our evidence-based practice is cervical cancer screening and treatment. So I mentioned that we are using the EPIS framework as our process framework. So we have different activities under the 4 EPIS phases. So the exploration phase, that was the phase where we identified, those barriers and as well as strategies. Some of those strategies were from the ERIC strategies, but particularly the core strategies, and the additional 2 strategies that made it the core plus. Then after the exploration phase is the preparation phase. That's the phase where we tailored and refined those strategies to make them more locally appropriate and culturally sensitive. Then the next phase will be the implementation phase. That's the phase where we'll be implementing the trial, so we have the core and core plus strategies, and we'll also be assessing our outcomes in the implementation phase. And the sustainment phase is also the phase that will be assessing one of our implementation outcome, which is the sustainment. So REAIM, like I said, it's our evaluation framework. Basically, evaluation framework is specifies the aspect of implementation that could be evaluated, to determine implementation success. So we are using it. Like I said, our study is hybrid and type 3. So we are looking at implementation outcome. Those are the primary focus. We are also collecting data on the clinical effectiveness. So we are looking at all the 5 dimensions of REAIM. Like Professor Marcia said, you don't necessarily have to look at all the 5, but you must be able to justify why you are looking at, particular dimension. Well, for us in this study, we are looking at all the dimensions. So we are looking at reach, effectiveness, adoption. Adoption for us in this study is the implementation strategy. We are looking at adoption of our implementation strategies. The implementation, we are looking at implementation strategy fidelity, as well as the clinical intervention fidelity. Well, then for the maintenance, which we described as sustainment in this study, just to align it with this EPIS framework. So how did we operationalize REAIM? I think the first thing you want to do if you want to operationalize, frameworks, your construct, it's a literature review just to see what has been done, in previous studies. So for us, that was the first thing we did. We wanted to see how REAIM has been used in the past, for similar studies, not necessarily cervical cancer, maybe similar studies. And we were lucky to find an interesting paper called Inspire. In that paper, they were looking at how system thinking approach to implementation of cervical cancer screening and treatment. So they use REAIM as one of the evaluation outcomes. And so we were able to, adapt some of the measures of the operationalized REAIM in that paper. This second paper was a systematic review and implementation strategies to improve cervical cancer prevention in sub-Saharan Africa. They didn't really use REAIM in the study, but they also reported on some outcome, and it was a very helpful paper. So first thing you do is to, do a literature review and see how these constructs, have been operationalized by previous studies. So these are definition of the dimensions for our study. So for us, REACH, we define it as cervical cancer screening rate. Adoption, again, was adoption, uptake of implementation strategies by health facilities. So we're measuring adoption at the level of the organizational or setting. Effectiveness was post-treatment negative screen. Implementation strategies, fidelity was delivery of implementation strategies according to protocol. Clinical intervention fidelity was delivery of cervical cancer screening, treatment, and referral according to protocol. And the sustainment for definition was the degree to which integration of cervical cancer screening and treatment continued, and factors that influence sustainment of the integrated cervical cancer screening and treatment services. So this were the definition of the dimensions in our study. So REACH, how do we plan to measure REACH? So for us, it was, we define it as percentage of enrolled women living with HIV screened for cervical cancer. So it's important as you are defining to also identify where you're going to obtain or get your data from. So for us, it was health records and participant survey. So for effectiveness, it's the percentage of women living with HIV with pre-invasive cancer who received treatment and had post-treatment negative screen at 12 months. And for data source, health records, as well as participant survey. So for adoption, so the adoption measures are all related to the strategies that we are implementation strategies. Like I said, we have 7 strategies in total, and the 5 core strategies, then additional 2 strategies for the core plus. So for example, the first one is percentage of health facilities that use the APN visual application Aviva for real-time support. So that Aviva, it's a mobile app that increases the accuracy of cervical cancer diagnosis, by providing real-time access to expert review, like gynecologists. So this is related to our strategy that is looking at providing ongoing consultation to those health facilities. The second one is the percentage of health facilities that participated in the quarterly stakeholders meeting. So this is related to our strategies that is on strengthening ties with stakeholders. Percentage of health facilities that initiated, quarterly educational meetings. So another strategy is to conduct educational meetings. So this also is looking at the adoption of that particular strategy. Another strategy that we have is strengthening referral system. So our adoption measure is the percentage of health facilities that identify the referral coordinator to follow through with referred women living with HIV with suspected cancer. We also have a strategy that's looking at preparing patients to be active participants. So for that, our adoption is the percentage of health facilities that distribute their flyers or leaflets on cervical cancer screening treatment in those clinics. Then the last 2 will only be in the core plus facilities. So we have percentage of health facilities that conducted the Healthy Beginning initiative at support group meetings. So this is tied to the strategy that is looking at community engagement through the Healthy Beginning initiative. And finally is the percentage of health facilities that captured the cervical cancer screening treatment data of recruited women living with HIV on smart cards. We also have a strategy that is looking at engaging patients through the use of mHealth platform. So this is tied to that particular strategy. So of course, we'll also be using a provider survey and documented record to assess this, the adoption measure. Then the implementation strategy fidelity. Here we are looking at the degree to which the core and core plus implementation strategies occurred in those facilities. So for the strategies, we have, for each of the strategies, we have a protocol on how the issue occurred, how they should be implemented. For example, there are some that they should have like quarterly meeting or weekly meeting. So we're going to be looking at how the implementation, according to that protocol. There are some that have some sub-activities they are supposed to do. So we're going to be looking at how the degree of adherence to this protocol in those facilities. And the sources will be through provider survey as well as documented records. So for the intervention fidelity, which is the cervical cancer screening and treatment itself, we are looking at percentage of women living with HIV with pre-invasive cancer who receive on-site treatment. So women are expected to receive on-site treatment. Also, we are looking at those that had post-treatment follow-up screening at 12 months is also part of the protocol, and also the referral for those who are have suspected cancer following screening. So it's a part of the protocol for cervical cancer screening and treatment, and we are going to be measuring this as our intervention fidelity. We're going to be looking at health records and participant survey to get the data on those measures. And finally is the sustainment, which so for this sustainment, we are using what we call the provider report of sustainment scale PRESS. It's a validated tool. It's a brief 3-item measure of sustainment. The items are measured on a 5-point scale, Likert scale, ranging from 0 to 4, and 0 is not at all, and 4 is to a very great extent. So that's the tool that we're going to be using to measure sustainment. And also, we are also doing focus group. So the measure of sustainment is actually mixed methods in our study, and the focus group will be looking at barriers and facilitators of sustainment in those health facilities. So that's how we plan to measure sustainment in our project. And okay, so once you've identified or operationalized the dimensions, it's also important to identify at what points of the study or what point of your project you are going to measure them. So this is what the slide is all about. It's just a summary of the different time points that we are going to be measuring outcomes. So you can see, for example, 6 months post baseline, we're going to be measuring adoption, fidelity. Wherever you see screening, that's talking about reach. Wherever you see treatment, it's about intervention, fidelity, referral, intervention, fidelity, follow-up screening is also intervention, fidelity, and effectiveness. And wherever you see PRESS, that's talking about sustainment, at the point we are going to measure our sustainment. So it's always good to once you operationalize the dimension, also identify the points in your project where this dimensions will be measured. So this is for our study. This is the schedule of assessment of those of the dimension and other outcomes we are looking at. So finally, what are the challenges that we faced in using REAM? I think the first thing I would say is in the selection of the evaluation framework, to even decide on the one to use. Because we considered, or there are other options available as to measure evaluation for us, and I think Professor Marshall really touched on it. For us, we actually considered the appropriate fit of the framework? Does he how easy is it to use? Is it does he will it give us what we are looking out for? I mean, the outcome that we are interested in. So those are the things we considered, and at the end of the day, we settled for a framework that was the best fit for the outcomes we are really interested in. I must say that there's a tool that is out there. It's called TCAST, an implementation theory comparison and selection tool that can also help in selection of theory or model or framework for implementation science. I came across this through some colleagues that we were working on a paper together a few months ago. So yes, so it can also, I've not used it before, but I think it's something that can also help in selecting or determining framework to use. Second issue I will say is in operationalizing and measuring the dimension of the re-aim. We had like, how do you measure adoption? Are you only interested in adoption of the strategies or evidence-based intervention? Do you use quantitative metrics? Do you use qualitative metrics? How do you measure fidelity? Do you add quality component to it? Are we interested in engagement? What type of instrument do you use? New instruments? Do you go for validated instruments? So those are some of the issues that we also had to deal with. And I think the first thing, and like I mentioned, literature review, it's always good to see what people have done or have used in the past, and that you can use in your context. I mean, other similar settings that you can also adopt for your study. And for us, an important component of our grants is the room for adaptation. And I think Professor Marcia also talked about this. So like I said, our first step was even focused on refinement, tailoring the implementation strategies that we've identified, to make them locally appropriate. So although we've already defined some of these constructs, we will continue to look at the outcome, implementation strategy and outcome measure, and see if there will be any reason for adaptation. We also are planning to document our adaptation using the frame. That's the framework for reporting adaptation and modification to evidence-based intervention. It has about 7 different, I think, elements that talks about like why the adaptation, was it planned and unplanned, who initiated the adaptation, things like that. So it's what we're going to be using, to document adaptation in our study. Finally, I will say that having an implementation and science expert in our team also, helped in resolving some of the issues and the problems or some of these challenges. We have one of the leading implementation scientists on this grant, and some of our team members have PhD in implementation science. So they are able to guide and help to make decisions on this and some of these issues. You don't necessarily have to be an implementation scientist to do an implementation research, but you actually need one in your team, to support you. I think that will be all. Thank you very much.
Thank you so much. Thank you so much, Dr. Olakunde. So, but Professor Marcia raised the question in the chat. So, Marcia, do you want to speak to that question you raised in the chat?
Yes, I think, right. I think at the very end, you talked a little bit about adaptation, but I think there's some tension in clinical trials where clinical trials don't usually want you to make any adaptations during. You can make the adaptation before and after. So you sort of talked about adaptation. Where in the process do you see adaptations coming in a formal clinical trial, even though it's a hybrid 3?
Okay, thank you. Thank you. Professor Sanole.
So one of the things that we look for in terms of adaptation, again, you see us trying to do the refinement. So as much as possible, we are trying to do the adaptations and the refinement upfront. So that's why we put it as our M1. So what we because the definitions, even though they are English, there are certain context to the definitions. So what we're trying to do is actually define it very well. So each of our strategies, we went back and had a team of 7 investigators meet 2 times every week for 2 hours each day to go over these things, to actually define them in local terms. Because at the end of the day, we have to teach the research coordinators what we want them to do, the people who are going to be at the site collecting the data. So we have to bring down that English and say, what is it that we actually want you to do? What do we mean when we say this? What do we mean when we say this? And at the end of the day, we also come in with saying, who will do this? So all those things that we discussed yesterday in terms of picking implementation, where you have to name it, you have to define it, you have to specify it. So that's most of what we did in the upfront in terms of those. But one of the things we want to do adaptation along the way is, for example, in the area of strengthening referral mechanism. So some of the things we have sites. The idea of our initial study is that there are 2 pathways to it. So they would do a VIA for women suspected of cervical cancer. If they find that the woman have a precancerous lesion that can be treated on site, it will be treated on site by thermal ablation. If that woman is unsure of whether it's a cancer or precancer and unsure of the thing that can be done, then that treatment is not given, but the referral is made to a tertiary institution. The success of that referral is bidirectional. One of them is to refer them to go to the site, maybe to get a biopsy, and then come back, and then the biopsy result comes out, and then you want to send them back for treatment. So in strengthening that relative, we put it in a way that is going to become dynamic. We don't know what we're exactly going to find. So for example, when we started the study, we have imagined that the people who will be doing the VIA will be the doctors. But when we now went to our 12th site, we find out that it wasn't the doctors doing the VIA, it was the nurses doing the VIA. That the doctors don't do the VIA. So there, first of all, in our training meeting, we had invited doctors. So first of all, we had to change that to invite the doctors and the nurses now, right? So suddenly we changed that. So even though it wasn't something that we do, this so good for us happened upfront. But what we are thinking is that when we now get to those referral systems, we might make adaptations depending on what we see. So yes, somebody might say it may affect those things, but we think, yes, it will. If we see that it's not working, we will document that it's not working, then we'll make the adaptation, then we'll now see whether the adaptation works. So what we are hoping is that we will make the adaptation, but we'll first of all document why we are making the adaptation. So let's say the referral system is not working. All the people we are referring never make it to the referral system. Then we have to do what is it that's causing that, make some changes to that, then we're going to reassess that again. So we're hoping to have some dynamic adaptations during that process.
So do you think that the adaptations are to implementation strategies, not to the intervention itself? Perhaps that's the differentiation.
Yes. So we're not going to adapt the evidence-based intervention itself. No, we're not. Because our thing basically is the implementation strategy. So we have outlined these 7 implementation strategies we hope from both work we've done before that are going to work. But we are not just going to say, well, let's keep doing it even if it's not working. So that's the implementation science. So we are hoping that those implementation strategies, that if they are not working, let me give you an example, one where we have done a real time. So we were doing a study where we were working with pregnant women in HIV. We were trying to increase HIV screening among pregnant women, and we're working with churches. And one of the things, a platform that we're doing is that we have a gift called the Mama Pack that had all the things the woman will need during delivery. So in the initial design, we designed that the priest will come in, call out the pregnant woman, pray for them, and then give those gifts to the pregnant woman. But one of the things we wanted to achieve was to involve the male partners. And we couldn't figure out how to involve the male partners. But along the way, one of our study coordinators said, instead of giving this directly from the priest to the woman, why don't we give it from the priest to the male partner to give to the wife as a gift? So we changed that. I can tell you our male involvement jumped from 30% to 88%. That's a 50% effect size difference. But it was made in implementation strategy as simple as that. So that's what we are hoping for, that if there are implementation strategies we can make adaptation to in real time, that will make them, as long as we're able to capture what happened before we did them, what happened after we did them, and why we did them anyway.
Thank you so much.
Thank you. So right now, there isn't any question that needs your attention here. I think we've gone through all the questions we have.
Let me answer some questions that I see
okay.
on the, and I think one is coming up, but I want to answer one of the things out there. One of them, and it's not related to the questions, but I think it's related to what I spoke about the NISA meetings. If the speaker that we have, just like we have Marcia now, if she allows for her slides to be sent out, we will send our slide. We will send slide out at the end, but we will only use emails at registration. So if your email at registration was wrong, unfortunately, you will not get the slides, because we do want you to use the right emails at registration. There are no need to put emails here, because we are not going to send, then we're not going to capture emails you put here. We're only going to use emails that you authorize us to use on the registration. That's the only one that we're going to send it to. We do know that over time, one of the things we have is all the detailed compilation of all the monthly webinars that we do and all the research weeks that we do are available to research NISA members. So what we encourage you to do is to go to the website. For example, if you actually register for conference this year, you can include membership for 2 years. That will authorize you so that you can have access to all our recordings for the monthly webinars and all our quarterly research network slides when it's authorized by the speaker. So go to the website again. It was put in there, and I'm asking Stephen to put that again. So you go to that website, register for the conference, and then that year, and then opt out for the 2-year membership. And that tells you that from 2023 to 2025, you will have access to all the recordings, all the slides of every program that we do. Thank you. So again, there's a Q&A, so you can go back.
Yeah, there's a question. So Marcia, the question here says, what are the most effective techniques to de-implement practices that are no longer effective or were never effective in the first place?
That is so hard. First of all, only recently have people looked at de-implementation, because what happens is, whether it's a clinical procedure, a policy, or a program, once one of those policies, practices, or programs get into practice, it's really hard to de-implement. But I think that money and resources are scarce. So again, it's taking what I would say a public health or a clinical perspective. Talk with your stakeholders, explain to them what the intervention or program is or isn't doing and for whom. Make it be a group decision. I think that just one person isn't going to work. It needs to be the people who would be spending their time and resources on implementation. So you talked about focus groups or key informant interviews. So there are a lot of programs in the US that are not effective, but they keep getting supported because they're politically popular, right? And I'm sure it's the same in every country, you know, whether it's HIV, AIDS, or other things. So I think the key is to find a group of key decision makers who are responsible for both the dissemination of the program as well as the support of the program, and talk to them about what's working and what isn't working and for whom. That would be my advice. Have you ever had a case in Nigeria where you successfully de-implemented? People talk about it theoretically, but I think it's hard to actually do it.
Thank you so much, Marcia.
You know, one thing that I wanted to add to that is, because what Marcia is saying is correct, you have to have the infrastructure to make those changes. And one of the things we have is that the National Practice-Based Research Network. So our Practice-Based Research Network is in all the regions of Nigeria. So one of the things we're doing, for example, we have a particular activity now we are trying to implement at all the 12 sites. And these 12 sites are 2 sites from each of the 6 regions of Nigeria. So we're working with the federal government and the Ministry of Health. And what we're trying to do, and the implementing partner, is to show a process for de-implementation. We're hoping that it's a pilot for us, that if we're able to successfully de-implement that activity, then that will become one of our local model of how we're going to do it. And you're right. The first thing is that we had to engage all the 12 facilities. We have to engage all these, policymakers in those 12 facilities. We have to, engage the implementing partner that supports them through the PEPFAR funding, because all those things matter. If you are going to de-implement it, who is funding it? Why do you want to implement it? So you have to show those sciences of why and what are you going to replace it with most of the time.
Exactly.
So those discussions are happening right now, and we are hoping that at the end of the day, that we will have some model of how to locally de-implement, because it happens to be one of the interests of Dr. Lakunde that is there, is the implementation. I happen to be one of my interests, which is how do you de-implement some of the things you don't want to continue?
Well, here's my question. Do you think that there's the same gap in time, 17 to 20 years for de-implementation? My hypothesis is that if you get the right people, de-implementation is quicker because it involves resources that could be reallocated. What is your hypothesis?
That's my hypothesis. We're actually looking at a 1-year de-implementation process. So that's huge, better than what you think with implementation. But the hard work is what is being done upfront. That engagement is being upfront. And I think one of the things we hypothesize that we're going to be able to do this in 1 year is that we have a replacement. So we have something that says this is not an evidence-based intervention. This is the evidence-based intervention. Can we swap it?
Right. Well, how the Administration for Community Living de-implemented immediately is they put a policy in effect that said they would not support non-evidence-based programs. So in essence, it took a national policy to say no funding for projects that have not been proven to be evidence-based, and they have a whole system where you get on an evidence-based roster. Is anything like that happening in Nigeria?
So the challenge with Nigeria is that the only way you do that is places where there is insurance. So you could say, we will not reimburse for this activity. In Nigeria, there's only 10% of people that have insurance. So if people want to pay to get the wrong thing, I can tell you in Nigeria, we pay to get the wrong thing, because we go to the pharmacies, we buy, we pay for it, they give us some concussion for our strain and pain, and whether it works or not, nobody cares. He gets the money, you get whatever psychological relief that you get. So a lot of things aren't proven, but there are some that are proven, especially when some of those things are supported by either funding from the federal government or from PEPFAR or from World Health Organization. So we think that mechanism is going to work. In this particular activity that we're trying to disengage, we are using those 2 factors. We are using, first of all, we want to do it at the 12 sites. We want to provide the government the data to say, this is ineffective. We can replace it with this that is effective and is better, so that the government can now use that as a principle to make a national-wide de-implementation process.
And will it cost them less? Will it cost them less? Because I think de-implementation and substitution.
Yes, absolutely.
That's
it costs them less, but yes, it costs them less. But more importantly is that there is an available evidence base that we can replace. So we are not, it's like when a child is playing with knife, we're not taking away the knife alone. We're taking away the knife and giving them a toy or something different that is, something that will not be harmful. So we're saying this is harmful, this is not harmful. We can switch them and at no additional cost. If anything, there's a cost reduction. So that's why we hope that we can get this done in a year.
That's excellent. And I'm so pleased that I bet you are going to be a national leader in this field, because everyone is struggling, mostly talking theoretically, but to actually have an example will be an incredible model for everyone.
Yeah, that's something that we're hoping that we can get done. Thank you so much.
Thank you. So right now, it looks like we don't have any more questions in the Q&A. No more questions in the chat.
So before we close again, I think I will use that opportunity. I think it's important. So pardon me if I'm emphasizing this, but I really think one of the things I noticed in my own career is that I remember publishing our first paper in Lancet, Global Health. And then I came back to go talk to the Ministry of Health. They said, we didn't even know about the study that you're doing. So it was published in Lancet. I presented in the meetings. It was adopted by the United Nations at one of the evidence-based intervention. And my Ministry of Health said they don't even know what the heck I did. So I think it's important as you start studies to be able to share those studies. That's why you see Olakunde sharing those studies. Those are important because as you become aware of what is happening in your environment and you see, then you want to actually see the results that come from that. And when you see the result that come from that, you are kind of following that study. So in terms of adapting, in terms of scale up, it's easier for you. So here again is a platform that we have for you to do that. So I do encourage you to register for this conference. For this year, this conference, we usually have it in September, and we have it with the Fogarty since 2015 every year. So we have had this with Fogarty, NIH Fogarty. But this year, we are going to have it in collaboration with also NCI, because NCI is funding 4 projects in Nigeria on cancer, reduction, elimination of cancer globally. So what they're doing is that they're holding their investigator meeting on August 14, 15, and 16 in Abuja. But almost all of those investigators and NIH will likely stay back for this 2-day meeting. So it is an opportunity for you not just to meet your colleagues, not just to present your work, but also to network with people from NIH, from other investigators that already have funded program from NIH. It is a place to look for mentors. It's a place to look for mentees, I always say, because for me, I look for mentees. I go to those the abstract. I look at very good abstract. I said, okay, I'm offering my time to you free of charge to help you get this abstract to publication. So in addition, as you're looking for mentors, there are people there looking for good mentees. People say, mentors are hard to find. I said that good mentees are also hard to find. So it's a very nice place for networking, and I hope you spend time to come. We actually have kept the cost of this conference down to 50 Naira with $100. That is the same price we charged in 2015. But we were able to keep that down because the member organizations that you have seen in the beginning, they have provided funding to make sure that the cost is not the reason why you cannot attend this conference, understanding economic challenges that exist in our country. But I hope that you will take time. I can tell you one thing, you will not regret it. Bridging that gap between implementation gap, between the science and the implementing partners and the implementation scientists. So how do we get to using that aim in actual work? Is very important, and that's why this week is a prelude to that conference. So pardon me for emphasizing that, but I hope that you could attend that. Thank you.
Thank you. So we have no more questions right now, and we have just 10 minutes to the end of the session.
So we can give them 10 minutes back for tomorrow.
Yes, okay. So I'd like to thank Professor Marcia Ori and Dr. Babayemi Olakunde for the wonderful session we've had with both of you today. I know the participants are very enthusiastic and happy to have had you today. And we wish you well in all your endeavors and hope that maybe you will see you again in some other session. Thank you so much for attending. Tomorrow is another day, 4 p.m. as usual. Let's be here for another very interesting session and have a nice rest of the day.
Thank you for inviting me. This has been very informative for me. And I hope one day to see you in person somewhere.
Yes. We look forward to meeting you in Abuja.
We look forward. Yes.
Take care.
Yes. Thank you. So bye-bye, everyone.
I just put up on the slide as people disengage, just the draft agenda for the conference, and so that you can see what we have in stock. Really, on the first day, we're going to talk about the evidence-based policy making, adapting evidence into policy decision making. As you see, this is she is the lead for our government and on HIV and all the facilities that are there. She is an NCI program officer, and we're having the investigators PI from there, as well as our PEPFAR country director and our country director for the cancer program. When we look at health system integration, addressing the role of context and implementation science. And then you see also we have those dual facilitators, but also we have the branch chief for NCI cancer. We have our own leads for the Ministry of Health, from non-communicable diseases, from mental health, from the United Nations. We do have our minister that always have come to this place. The minister has always come to these conferences that we hope that this year is going to come. One of the other places we have the innovative approaches to generate evidence-based practices. And we talk about the NCI Deputy Director is going to be there. We have our own team. Dr. Nyeka is going to be there. We have Dr. Jen DeVoe, who also runs the Bridge C2, which is a practice-based network also in the US, to share with us their experience from that. We have a member of our team from the country also here to talk about it. And we have and from Hologic, who was at Hopkins and was one of our investigators on our study. So we go on to look at NGTs and nominal group technique for stakeholder engagement. The day 2 is really left for you. We're going to have a lot of things, leveraging HIV infrastructure for the emerging infection and non-communicable diseases. We are going to have the top 10 abstract that is going to be there. We're going to go in there to developing a pipeline of early career implementation scientists in Nigeria. This is really, really very cool. For those who are going to come, you're going to hear a lot from those people who have benefited from it, those people who have early beginners in implementation times, those people who are established already, and they're going to have a discussion about how their career is moving and how they can move it forward. We're going to talk about creating the partnership between the NGOs and the academic institution. This is critical for sustainment for all the work that we do. And we're bringing people from implementing partners, from the government, from the universities, to share the things that they have done under that. So, and we end up with a gala night. And then if you haven't seen me dance, you can come and see me dance. I think the last year, stop laughing, Dr. Nyeka, but the last year I was trying to show Dr. Aarons how to dance some of our popular Nigerian music. But I think there's new ones that just came out now and I've been practicing. So I really want you to come to the dinner and the award ceremony to see the dancing steps. Maybe for Dr. Onyeka laughing at me, I am going to compete with her and then see who is a better dancer. But thank you all so much, and hope to see you tomorrow. Thank you, everyone.
Thank you, everyone, and bye-bye.
Thank you. Bye.